Hi guys, so we are in the masterclass on post burns neck reconstruction, and in this video we were going to typically see how to assess a long case from exam point of view, how to do the inspection, palpation, what all things to include, and how to eventually come to a diagnosis of post burns neck contracture. Rather, I mean to say how contractures in all are a very difficult problem. They are difficult from anesthesia point of view, from plastic surgeon's point of view. They are also very difficult. There is no forward gaze for this patient, so he can have headaches. These type of patients where in the young age group these burns are involved, they tend to be socially withdrawn as well. There can be depression issues. There can be sleep problems due to itching. Just to recap the chief complaints, in case I have missed some, there can be lip seal problems, salivary drool, mandibular prognathism, occlusal issues, either thermal or scald or electrical burns. The type of clothing which the patient wore at that point of time is important, because some sort of synthetic, because burn contractures patient have got multiple contractures. They probably are in and out of the hospital many times. They are nutritionally depleted because and in addition they are going to need multiple surgeries. So that is why to have a optimal status of nutrition is very important, relevant to the history, and the chief complaints obviously needs to be inspected. Now in this patient, let us see what all are the inspectory findings. The attitude of the neck. In this case, the attitude of the neck, although the patient is attempting extension, the attitude in a normal condition would be of flexion. When attempting extension, there is mouth opening because of the extrinsic contracture. So how do we know that this contracture is extrinsic or intrinsic? We will come to that in the next slide. So our passive range of movement is limited only by the soft tissue contractures. But yes, even then we need to assess it. Again, just for the sake of completion, the scar assessment is done on 4 parameters. This we are talking of the Vancouver scale. We ascertain the hypertrophy, the pigmentation, the pliability and vascularity, and give a scoring system to the scar based on these criteria. The scar score might be different in different areas of the scar, because how the scar behaves at some places, there might be hyperpigmentation, there might be hypopigmentation. So our scar assessment may vary from area to area, and we can describe a rough outline that the Vancouver scar score ranges from so and so number in this particular place to so and so number in that particular place. So as I said, we will have a in-depth, in-detailed video of how to assess a Vancouver scale, but just a quick revision of what all factors are involved. The height part is done, and now we have come to our diagnosis. So in diagnosis, we have to include all these findings. The patient is in more contact with the burns, which typically happens in cases of epilepsy or if the patient is alcoholic. But here we have almost in limited excision and grafting. So only that part of the scar which was overlying the neck, which was causing neck contractures, is excised. The part of the hypertrophy of the scar which is there over the chest region, which is involving or probably encroaching on the anterior axilla, is not touched. We hope that it will be taken care of to some extent, at least by pressure garments. So these are the pre-op and post-op outcomes with neck in extension. And these are the pre-op and post-op outcomes with a frontal gaze. You can appreciate that a very good cervicomental angle is evident right now as compared to the pre-op thing. The scars, the grafts over the